Hello, and on behalf of the Advanced Renal Education Program and the Nephrology Campus, welcome to the sixth series of webinars entitled Multitargeted Interventions to Reduce Dialysis-Induced Systemic Stress. My name is Professor Peter Stammekel, and I work as a professor and senior lecturer at the Department of Renal Medicine, the Karolinska University Hospital, the Karolinska Institute in Stockholm in Sweden. And I will be your moderator for this session. First, I want to say a big thank you to all the healthcare workers as you continue to provide world-class care to our patients. We have a large number of attendees today, and all lines have been muted as a courtesy. We do, however, want you to engage with us during the program. In the user panel, please feel free to submit your comments and questions at any time during the program. We have also included handouts of both the presentation and literature article which will be discussed today. If you have any additional questions after the webinar, please send an email to the respective region seen on this slide. So we are now halfway through our hemodialysis spotlight webinars. Over the course of these 8 webinars, we are discussing articles from the supplement recently published in the Clinical Kidney Journal entitled The Duality of Dialysis Membranes, the Attributes and Ramifications. And with these webinars, we aim to help facilitate a better understanding of the functioning principles of hemodialysis with a focus on the critical role of dialysis membranes. Be sure to register to attend when you receive the announcement via email. We will share upcoming dates later in the program. And this educational program has been developed by the Medical Information and Education Office of the Fresenius Medical Care. It is intended to provide pertinent data to assist healthcare professionals in forming their own conclusions and making decisions. And it's not intended to replace the judgment or experience of the attending physician or other medical professionals. And of course, the treatment prescription is the sole responsibility of the attending physician. If you're interested in additional renal-specific educational content, I would like to invite you to browse the Advanced Renal Education Program's comprehensive online platform. And this includes e-learning courses, review articles, a repository of previous webinars on demand, and a dedicated literature search. There are also flyers and posters available on request. To quickly access the website, you can scan this QR code here or visit directly at advancedrenaleducation.com. And today we have a distinguished panelist, Professor Bernard Canaud. He's currently an emeritus professor of nephrology at the Montpellier University School of Medicine. And Professor Canaud headed the nephrology, dialysis, and intensive care department for 25 years at Le Perron University Hospital in Montpellier. His main topics of interest include renal replacement therapy, uremic toxicity, vascular access, dialysis efficacy, nutrition, anemia, and epidemiology of chronic kidney disease and its practice patterns. Professor Canaud has contributed to the elaboration and production of the European best practice guidelines, particularly on dialysis fluid purity, water access, dialysis adequacy, and anemia management. He is currently the Senior Chief Scientist in the Global Medical Office at the Fresenius Medical Care. He acted as a Chief Medical Officer for the EMEA LA region at the Fresenius Medical Care from 2012 to 18. And he has published more than 400 peer-reviewed articles, contributed to more than 80 textbook chapters, and he has attended more than 1,000 scientific medical meetings. Professor Canaud has also received several awards and distinctions from international nephrology societies, including the very prestigious Belding-Scribner Award from the International Society of Hemodialysis. This was in 2010. He also received the Légion d'honneur as a recognition for his lifetime of medical achievement from the French president at that time, President Sarkozy, and that was in 2009. In March 2019, the ADC and Missouri University in the United States awarded him for his lifetime achievement in nephrology and commitment to renal replacement therapy. So, I would now like to turn the webinar over to Professor Canaud.
Thank you very much, Professor Stenwinkel. So, a very kind introduction, nice words, which make me, I will say, a little bit humble. So the target today is just to talk about what we learn about 50 or 60 years as a sort of dialysis-induced systemic stress. And the idea is to show that maybe with an optimal way of treating the patient, we can, based on a multi-targeted intervention, reduce this dialysis-induced systematic stress. This is part of the article from the CKG journal. I am currently the senior chief scientist in the global medical office. Just to make sure that you are not confused, I put, of course, from this article, I put a lot of graphs, not necessarily taken from the article, but this is just based on illustration. So the outline today, I just want to show you some facts and figures regarding renal replacement therapy, where we are, and certainly where we want to move from. The conventional intermittent dialysis treatment is associated with a multi-systemic stress, and I will show you in a minute how the main factors are implicated in this dialysis-induced systemic stress, and what could be the various approaches to mitigate this dialysis-induced systemic stress. This is a large program. So the first aspect is the fact and figures, and you know almost everything. So I will not go into detail, but just looking on 4, I would say, items. Hemodialysis is supporting life of, I would say, 2.3 million minimum. Worldwide, it's expected to be double within 2030. So that means we recognize that dialysis is a life-supporting technique. Now, the second aspect, which is on the bottom, is the cardiovascular mortality. Still, after 60 years, we know that mortality is almost 10 to 100 times higher, depending on age, population. But still, if you look, almost 55% of the mortality in dialysis patients is coming from cardiovascular origin. So something has to do with the cardiovascular risk in dialysis. But the third point is, of course, dialysis is a quite economical burden. It's represent, depending on the country or depending on the continent, between 2 to 3% of the healthcare expenditure. So we need to improve the treatment to reduce such a cost. And the last point, which is not the least one, this is a patient perception. This is just to show that the quality of life, depending what you take as a study, but it's 50 to 60% less as compared to the general population. So something has to be done to improve such fact. Unfortunately, the conventional treatment, what we call intermittent, standard, I would say, hemodialysis, has a lot of physiologic aspect. I just put from the left to the right, a large fluctuation of the internal milieu. I don't want to go into detail from the weight of fluid, I would say variation, the blood pressure, the electrolyte, uremic toxin, which are moving from peak and I would say valley. So this is not physiologic. We know that stability of homeostasis in a human being is quite important. But the second aspect, on the middle, if you just consider the casino concept, which is based on equivalent of kidney function based on urea, you can just recognize that delivering, I would say, adequate dialysis, 1.4, 1.6, 3 times a week is just restoring about 15 to 20% of the kidney function. So we are far from our optimal. And the last point, any dialysis session is associated with some bioincompatibility that we call hemobiologic reaction. And this is with, I would say, improvement over the time, but still remaining some, I would say, fat activating cells and protein I will show you in a minute. So based on this element, and of course, using renal replacement therapy to improve the outcome of the patient, we know that there is a complex array of consideration just to consider, from the comorbid condition to the patient trajectory, support function, healthcare system. I don't want to go into detail of this element. Just to focus on one, which is a central one, renal replacement therapy. So just focusing on one element, but considering this is part of the puzzle that we have to face. So the second aspect is, of course, conventional intermittent dialysis, I will show in a minute, is associated with a multi-systemic stress. And in this multi-systemic stress, which call now dialysis-induced systemic stress, is a strong disease modifier. As you can recognize from the left to the right, any dialysis session is associated with the stresses, which are maybe, depending on the adaptive mechanism, could be corrected or not, but has some consequences on the functionality, on the somatic function of the patient, and they act as a disease modifier. So they can relieve uremic symptoms, but on the other side, they can create the dialysis-related disease, so that at the end, something is beneficial on the one aspect, and something is a little bit more deleterious on the other side. This is not. Now, what is a dialysis-induced systemic stress? And I put in a very simple way. On the left side, this is a major one. This is hemodynamic stress. And there is two phases. One is an interdialytic phase where the patient is gaining volume, so volume overload, hypertension, and so on. And during the dialysis time, or the intradialytic, we are removing this fluid. So we create a volume depletion. So this is hemodynamic, which is on one side overload and the other side depletion, and just reflecting a sort of tide up and down phenomenon. And on the right side, you can recognize also non-hemodynamic stress. And in this category, you have the hemobiologic reaction, some associated with the hemo-incompatibility of the system, and some just based on the biological shift from the osmotic, electrolyte, nutritional, depletion, catabolism. So I don't want to go into detail of this element, but you understand the complexity of the system. Now, just putting on a very simple way, hemodynamic stress. On the top, you get what happened during the interdialytic period, this hypervolemic condition. And on the bottom part, you get what happened during the dialysis session, the depletion. And you know that both are acting on the hemodynamic consequences, either from the fluid overload or the fluid depletion, and then having the target organ damage. I will come to this point later. Just remember, this is a tide phenomenon, up and down 3 times a week. Now, the second aspect is a non-hemodynamic stress. And this is part of what we call hemo-incompatibility. I don't want again to go into detail, but we know as soon as we start the dialysis, the coagulation phase is activated, the complement activation is stimulated, the oxidative stress is also activated by the release or the removal or the clearances of antioxidant substances, and the cytokine and inflammation are part of the game. So this is also together sort of hemo-incompatibility system who are part of the stress. Now, the technique to assess this dialysis-induced systemic stress, of course, we can assess from the clinical or from the clinician perspective, and you know how to assess the blood pressure, the volume depletion, but that's not very sensitive. We can use much more sophisticated tools, such as with the blood volume monitoring. I will show you bioimpedance, lung ultrasound. We can use biomarkers, and we can use something which is fascinating, is a functional imaging. And the organ, MRI, is certainly the most interesting aspect to explore such dialysis-induced systemic stress. Now, I'm sorry, too fast. So, just in summary, the pathway, you understand from the left to the right. Hemodialysis session, stress, hemodynamic, non-hemodynamic, crosstalk, organ damage, and this is part of the outcome of the patient, affecting the quality of life, contributing to the hospitalization, morbidity, and death sometime to the patient. So this is some example I will show you in a minute. Multisystemic stress with a different example on organ damage from the cardiac, the brain, the gut, and the liver, and the kidney. I don't want to go into detail, but just to show what the powerful of this new imaging technology. This is example of a study was performed in Nottingham, Derby in UK, assessing dialysis patient during the dialysis session with MRI. And then you can get access to cardiac, brain, kidney, liver, skin now, but you can find, I would say, immediate impact of the dialysis session to the patient. So the first aspect is just to look on the cardiac system and hemodynamic functionality. I don't want again to describe, but you can see the blood pressure change, the cardiac functionality, cardiac index, heart rate, and also from the study, unfortunately, in that point, you see that it's related to the ultrafiltration rate. That was a comparison between the hemodialysis versus hemodiafiltration, but at the end, you understand that the ultrafiltration rate and the ultrafiltration volume is the main driving force for such element. But what is found is a tremendous impact on the cardiac study. And this is clearly associated with the ultrafiltration rate, showing that, I would say, some abnormality of the left ventricular functionality are stern, as you see on the slide, and also strain of the cardiac system is affected by the ultrafiltration. Not only the functionality and the morphology, but also the perfusion. If you just look, sorry, too fast. If you look on the perfusion, on the myocardial perfusion, you see that during the peak stress, which is the maximum hypotension, there is a tremendous, I would say, hypoperfusion coming from the myocardium. And you understand clearly that this is associated with ischemic, I would say, disease. So the cardiac stenting is associated with abnormality of the motion on the left side, but also on the myocardial ischemia as shown on the right side. So this is an increase of troponin C, for example. Now, not only the heart, but if you just think about the brain, and this is a study that was performed in UK for 1 year, just considering, I would say, cerebral hypoperfusion. So on the top, you get the baseline, and on the bottom part, you get after 1 year, showing that there is a tremendous impact on the white matter. You can reduce, and I will show you in a minute, this impact by using, for example, hypothermic dialysis, but still, white matter is affected by the dialysis. Now, not only the heart, the brain, and now the kidney. Look what's happened on the kidney. If you just monitor the kidney perfusion during the dialysis session, as soon as you get a peak stress, there is a tremendous reduction of the kidney function and the kidney perfusion, meaning that certainly what kills the kidney function is the ischemic insult on 3 times repetitive aspect during the week. So, what are the factors implicated in dialysis-induced systemic stress? As I showed you a few minutes ago, one is hemodynamic stress, but the other one is hemobiologic stress, and this is part of the interaction between the blood membrane and dialysis. Biochemical stress and the shift with the different composition, osmotic shift, electrolyte, and uremic stress, certainly as a residual part of the renal replacement therapy and sufficiency in terms of, I would say, efficiency. So I will take some example. Hemodynamic systemic stress. So I selected 3, fluid overload and hypertension, hypotension and hypovolemia, and cardiac arrhythmia. As you know, the fluid overload is quite common. I will show in a minute, it's almost 50 to 60% of the patient. But on this retrospective study, with a large numbers of patients, almost 9,000 patients, you can see the impact of high fluid overload versus moderate or normal fluid status. So the impact on the pre-dialysis or post-dialysis is a tremendous. So the blue line is, I would say, almost normal volemic condition, and the blue light, which is on the bottom, show you within 1 year almost 30% mortality increase. So we know that high fluid overload is associated with a tremendous risk of mortality. So this is also from Zoccali, confirming the same information. If you just look on this almost 40,000 incident population, almost 50% of the patient present, I would say, high fluid overload over 2.7 liters. And also on the right side, you can see the hypertension impact. Depending on the level or threshold value for the systolic blood pressure, you can move up to 20% or even 70% if you select what the KDIGO is recommending 130. So up to you, but still we have to do something on a patient to correct the fluid overload and the pressure. Now, the interesting point from this study is not the pressure, but look the impact on the fluid overload on the baseline mortality. Whatever is the level of pressure, the fluid overload is associated with a 30 to 40% higher mortality, almost independently from the pressure. Now, 1 year later, if you monitor and you follow up the patient and you are not able to correct the fluid overload, see the impact on fluid overload 1 year later, from 30 to 60% mortality relative risk is increased, meaning that pressure has some impact on mortality, but the fluid overload is much more, I would say, important on the mortality, and we need to correct that. So, just in summary, from the antidialytic period, sodium accumulation, hypertension is associated with so many, I would say, side effects on cardiac failure, arrhythmia, brain damage, atherosclerotic inflammation, malnutrition, lung dysfunction. I don't want to detail all these elements, but this is what we observe. Now, the second aspect is, of course, how to create this fluid overload. And of course, the idea is just remove the excess of fluid by ultrafiltering the patient. But then this is the next challenge. And this is the position of the nephrologist exposed to either to chronic fluid overload or acute hemodynamic stress by inducing hypovolemia, intradiabetic hypotension, and so on. So it's a permanent, I would say, imbalance between fluid overload and fluid depletion. So the point is to manage this very challenging situation. During the dialysis, we can act on different factors. Of course, we can reduce ultrafiltration rate by increasing the time, I will show you. We can facilitate the vascular refilling capacity. We can act on the cardiac output. We can act on the peripheral vascular resistance. So that means we can act on the hemodynamic response by, for example, acting on the thermal balance. I will show you in a minute. So there are some action points where we can act. Just this study, which was almost performed 15 years ago, just very impressive study. In that case, they implanted a sensor device in the lung artery of the dialysis patient, and the patient were monitored for 1 week. Just to give you an idea, the mean arterial pressure is normally 20 millimeters of mercury. And if you see the upper line and the lower line from the patient, at the end, they never achieve such, I would say, 20 millimeters of mercury. They are either twice over or maybe lower. So that means they are fluctuating between the fluid overload and high pulmonary pressure and the low or hypovolemic condition and the low pulmonary pressure. Now, acting on the ultrafiltration and flight, the group clearly shown that higher ultrafiltration rate, and in that case more than 13 ml per hour per kilo, is associated with higher risk of all cause, but particularly with cardiovascular mortality. And of course, you understand that high ultrafiltration rate is associated with a tremendous hemodynamic instability and then create hypotension. And the same group clearly shown that every episode of hypotension, intradiabetic hypotension less than 90 millimeters of mercury, is associated with higher risk, between 40 and 60% higher risk of mortality. So you understand the link between high fluid removal, hypotension, and this, I would say, high risk of cardiovascular mortality. This is summarized in this slide. So this is what we create during the intradiabetic period, high ultrafiltration, hypovolemic, and depending on the hemodynamic response. So we can affect the cardiac system, the brain, gut translocation, inflammation, liver, renal ischemia. So this is just to confirm this tied up and tied down phenomenon. The second point is the cardiac arrhythmia. And we know now with the implantable device, we will link, and this is a study which is a systematic review, including almost 1,600 patients. They clearly show, I will show you in a minute, that this incidence of cardiac arrhythmia is much higher than expected before. And just show you this result from 320 patients, 5 study, showing that at the end, death rate is 14%, sudden cardiac death is 6%. But look on the incidence of bradycardia, asystole, which is 90%, sustained ventricular tachycardia, 2%, atrial fibrillation, between 19 and 26%. So you understand that this arrhythmia incidence is much higher than expected, and certainly what is reported by the clinical, I would say, hospitalization or management of this patient. And the second aspect is a non-hemodynamic factors, non-systemic stress factors. I will cover different elements: hypoxemia, thermal balance, biochemical, and bioincompatibility element. So the first element is, of course, does that move? Okay. This is the hypoxemia. And just to show you that hypoxemia is part of, I would say, almost or affecting 10% of the dialysis patient. This is a study which was performed in New York in almost 1,000 patients. But as shown, 10% of the dialysis patient present, I would say, a significant hypoxia during the dialysis session. Significant meaning that they get lower than 90 millimeter of mercury. And what happened to this patient who get hypoxemic during the dialysis session? If you follow the patient next year, you see that the impact on mortality is very impressive. 15% higher mortality rate in this hypoxemic population. So what is the reason of the hypoxemia? We can speculate. I don't have the answer. Second aspect is what is the impact of hypothermic dialysis. So hypothermic dialysis is shown very beneficial in the patient, and hypothermic dialysis could be done in automated way or could be done manually by reducing dialysate temperatures by 0.5 degree. But as shall be shown clearly, in all cases, hypothermic dialysis is associated with a better hemodynamic stability, better blood pressure preservation, and I would say tremendous reduction of the intradialytic hypotension. As shown on this slide, is almost 20% reduction of the intradialytic hypotension. Third element is, of course, freed dialysis, freed potassium concentration, and particularly the change in potassium is very associated with higher risk of mortality. This is coming by Kalantazaki group, showing that, of course, dialysate potassium, if you are using 2 or 3, the risk is limited. So that means the gradient between the dialysate and the plasma is relatively low, meaning that the fluxes are very low. Now, if you are using a dialysate potassium of 1, you see the impact on mortality, and that clearly is associated with arrhythmia, as shown a few minutes ago. So, the last point is a complement activation, and it was shown by Populars that the activation of the complement in some subgroup of patients is associated with a predictive cardiovascular mortality. And over the long term, if you are using the mannose binding lectin, which is a way of clearing this C3, C5a, higher you get, I would say, the mannose binding, meaning low complement activation, you are protected against the cardiovascular event. So there are some still remaining, I would say, toxicity of the complement activation. Inflammation, and this is by our chairman, Peter Steinwinkel, show that clearly in this arrow consumption, the association of inflammation change completely the profile of the BMI. As you know, the BMI, higher you get a BMI and higher you are protected in dialysis. But if you put BMI and inflammation, this is just on the reverse side, meaning that inflammation is associated, and in that case was a CRP and albumin level, is associated or just as a paradoxical relationship and change this relationship or protective effect of this element. So how to protect and to mitigate this element? This is part of the element. I will go on some, not all, but we can have some cardioprotective action, some track. Treatment time, increasing blood volume monitoring, blood volume management, thermal balance, sodium management, and in the future predictive medicine could be part of this new game. Increasing treatment time, that's certainly the easiest way to reduce cardiac stress. And that was clearly shown by Jeffrey and McIntyre, just showing that from regular intermittent dialysis to nocturnal or daily dialysis, you reduce the ultrafiltration rate, ultrafiltration volume, you reduce cardiac stunning, and this is almost linearly correlated. So that means lower is ultrafiltration and lower is the cardiac stunning of the patient. But now you have to convince your patient to increase treatment time. As I showed you a few minutes ago, we can act on the dialysis by increasing the time or acting on some element, and particularly on the volumic control, I will show in a minute, or the hemodynamic response by modulating on the thermal balance system. Biofeedback control of the volemia has been shown by Shelby in randomized study to be associated with a tremendous beneficial effect on the cardiac study. Shown on this slide, standard hemodialysis on the top and biofeedback control on the bottom part show that you can reduce tremendously peak stress and reduce cardiac stunning. So that's the point which is illustrating the role of the volemia control. Now, just playing on other topic, which is hypothermic dialysis, and we know from Maggiore 20 years ago that hypothermic dialysis is associated with a reduction of intradialytic hypotension. This is clear. Not only, but it's affected, in, as you see, the left ventricular mass, peak systolic strain, and all these elements are protected. So the last point, this is the sodium management, and we know that we have another way of acting. We know that almost 80 to 90% of the sodium is removed by the convective action or the ultrafiltration, but we can act on the fine-tuning on the diffusive one, which is the dialysate plasma. This is a way to modulate sodium mass removal, but also to modulate tonicity of the patient, which is very important for dialysis tolerance and to reduce certainly the thirst. So we get on the machine a new device or option, which is called sodium management. So this is part of the element. So sodium, volume, pressure. So we have a complete setup to make sure that at the end we can improve the patient. And cover some of the element. I will not cover all these elements. And the last point is non-hemodynamic stress. It's also desirable. Some track, hemodialyzer to reduce hemo incompatibility, more efficient technique, use of electrolyte fluxes, modulate oxygen supply. Just some elements, complement activation can be reduced depending on the membrane. This is shown on this study, showing that by adding some PVP to the polysulfone, you can reduce tremendously the activation. Now, acting on the hemodiafiltration, so increasing the convective volume and increasing the convective clearances, as shown in this Spanish study using a very specific global removal score, making, I would say, the average of, I would say, molecular removal from urea up to acid glycoprotein, so that means from the low to the very high. It's clearly shown that hemodiafiltration do perform much better than all the techniques. So that means we know that today the high volume hemodiafiltration is the best way to remove such middle and large molecular substances. Acting on the anticoagulation also, just in that case, injecting the low molecular weight, not on the arterial side, but just on the venous side, shows that you can reduce thrombosis risk and you can reduce almost by 50% this consumption of erythropoietin. Potassium modeling is coming, and that's also shown in the study that reducing the fluxes of the potassium improves tremendously hemodynamic tolerance of the patient. And the last point, this is part of the, I would say, future predictive medicine. If you collect the information and you can anticipate what would be the mortality risk of the patient, then you can anticipate what would be the best treatment modality, so you can personalize the treatment for the patient and adjust the treatment according to the patient needs. So as a take-home message, I just want to say, if we just move away from cost consensus rather than physiology and or personalized based therapy in dialysis, we can improve tremendously treatment tolerance, and we can improve tremendously the long-term outcome. So just remember, dialysis-induced systemic stress is, I would say, a tremendous element that we can modify, which affect the overall quality of life of the patient, but certainly much more the end organ damaging effect, meaning that this is a disease modifier who can impact the mortality of the patient. So we need to have a more balanced and precise approach. So we need to adjust the treatment to the patient and not to feed the patient to the treatment. This is something which need to be implemented. So just make sure that a broader approach embracing the entire management of the dialysis patient with a more physiologic based and holistic, I would say, way of treating the patient in order to reduce this dialysis-induced systematic stress and to prevent all these multifactorial components, and certainly to reduce this impact on the mortality. This is just summarized on this slide. 4 main streams to improve patient outcome. We need to personalize and optimize the kidney replacement therapy. We have to consider increasing treatment time or frequency. We need to integrate the kidney treatment in patient trajectory care. And we need to use innovative technology, as I show you, online hemodialysis tool, offline tools, and all these elements to make sure that we can fit with a better treatment for the patient. Thank you for your kind attention, and happy to take your question.
Thank you so much, Professor Canaud. This was a great talk covering multi-targeted interventions. And we have time for questions, so please post your questions in the chat. Meanwhile, I start with some questions that we already have received. Does the length of a single hemodialysis treatment impact the systemic stress?
You mean one session?
Yeah, one single hemodialysis treatment, though the length.
This is the point. Sure. The point is, of course, one session is affecting, I would say, the systemic stress, but the point is a little bit more on the repetitive action. And one I mentioned, for example, hypotension, 90 millimeter of mercury. It's clear that a lot of studies show that if the frequency of this hypotensive episode is multiple during the dialysis session or repetitive over the months, it's clearly affecting the mortality of the patient. So it's not only just based on one session, but the repetitive action and the cycling process is certainly, I would say, affecting much more the patient. So we need to consider, I don't want to say only one session will kill the patient. It's not true, but certainly the repetitive action and the cumulative action of this side effect is clearly deleterious for the patient.
Mm-hmm. Another interesting question here. Is Benadryl intravenously an option for anxiety during hemodialysis? And also a question, is there a research about the use of cannabis for anxiety in hemodialysis patients?
Okay. That's, I would say, a different topic, I would say. Now, using anxiolytic substances during the dialysis session makes sense, but of course, it would not prevent this systemic stress. It will prevent the anxiety of the patient. Maybe the patient will be relaxed, but I would say side effect of the dialysis and all this systemic stress will still occur. Now, what will be the impact on the cannabis on this element? I don't want to go into detail. I don't have any experience, but I just want to give and share this information. I remember in Canada, a group 5 or 6 years ago was looking on the dialysate side to make a quantification of uremic toxin removal, and they found that in a dialysis population, almost 20% of the patients were taking some cannabisoid substances. Just to give you an idea, meaning that, I don't know if somebody look in Europe, but that was in Canada. So that means some patients are already using, I would say, some cannabis or cannabinoid substances. So I don't know what is the impact on the session. Does it improve the tolerance? But it's a fact.
We have a question from the home hemodialysis nurse. He or she states that 90% of my patients feel a bit anxious about feeling cold for 4 hours while on the machine. How best can we manage this feeling, the coldness?
Okay, that's a very interesting question, because of course this is also personal, I would say, feeling. What is recommended when I'm talking about hypothermic dialysis is just, if you do that manually, it's just reduced by 0.5 degrees Celsius from the core temperature. And usually the patient does not feel so bad with this small change in temperature. Now, some patients will feel certainly bad, depending on the thermal balance that they have. And certainly it would be much more useful to use a thermal balance based on an automated system on the machine to reduce this element. So depending on the threshold sensitivity of the patient, I can understand. But from my personal experience, 0.5 degree is just a way to make a sort of neutral, or I would say less hypothermal change during the dialysis, which is not perceived by the patient so badly. So maybe, I don't know what is the exact temperature that the patient they get, but it would be interesting to check the core temperature of the patient, and just to make sure that they can adjust or align the thermal temperatures of the patient, of the dialysate side, and to reduce only by 0.5 degrees. That's my, I would say, clinician recommendation. Or use a blood thermal module to make sure that at the end the thermal balance is neutral or close to neutral.
So we have a comment here. Let's see from let's see here, Jorge Roman Lator. Back to Benadryl. Diphenhydramine has alpha blocking effect, especially if given intravenously. Dangerous drug to use as sedative in hemo. It may cause hypotension. So that is more like a comment about the Benadryl.
Yeah, but he's right. He's right. This is right. Benadryl, I think it's alpha blocker, is not good during the dialysis. I did not mention about the medication, but this is also true for calcium channel blockers. If the patient is taking calcium channel blockers, you get a lot of difficulty to remove the ultrafiltration, and then you have a lot of difficulty to stabilize the hemodynamic, I would say, stability during the dialysis, because you cannot mobilize, and the refilling vascular capacity is tremendously reduced by the calcium channel blockers. So this is another medication who can affect such, I would say, hemodynamic stability. So
here's a question from Cecilia Schultz. There, Bernard, do you believe that protecting the residual renal function as it is done in PD patients is a good strategy to reduce the intradialytic ischemic stress due to the reduced ultrafiltration rate applied? Maybe you can see
certainly, and you're right, Cecilia. That's certainly true. If you can preserve, but the point is, of course, how to preserve the residual kidney function. You can do that in the initial period of the treatment, I would say, within the first 6 months or 12 months. And if you have a very specific, I would say, incremental program, for example, where you move slowly from 1, 2, or 3 sessions a week, and then you can prevent this hemodynamic stress, then that prevents to kill the kidney function. So preserving the residual kidney function is certainly beneficial for the patient. It's certainly beneficial to reduce weight gain and then to reduce ultrafiltration, and then to reduce hypotension. This is clear, but the point is how to preserve the kidney function. This is another question. It's possible within 6 months or the initial period of treatment, or the 12 months. The people from Manchester and London have shown that incrementally modification, for example, they can preserve the kidney function up to 2 years, but you need to implement this residual kidney function in an incremental dialysis program. Otherwise, it's quite difficult to preserve the kidney function and then to take any benefits. But of course, beneficial effect of kidney function is not on the fluid status of the patient and to reduce his systemic stress, but it's also beneficial for the control of uremic toxin, and particular for middle molecule or protein-bound uremic toxins. That has been shown in several studies, and our chairman can comment much more than me on this topic. So preserving the kidney function is always beneficial.
And here is a broad question. What is the current research on cardiac stress during dialysis?
There is a lot of, I would say, study running, and particularly with this cardiac MRI. So the point is, so not only cardiac MRI, but stress is now, if you get access to this functional imaging with MRI, you can have at the same time the cardiac functionality, the brain, the liver, and the kidney. And this is exactly what is done in Canada and done in Nottingham in UK and in Groningen in Netherlands. So this is the 3 main groups working on this topic. The point is, of course, it's clear that something is wrong during the dialysis session. The point is to find a way to prevent this stress. And unfortunately, I can show you something has been submitted. Unfortunately, I cannot show the result. But even if you control the temperatures, if you control the volemia, if you control almost everything, still there is a, I would say, remaining stress which is affecting the heart and the brain. So the next question, and this is why I put this biological stress, I'm convinced that part of the stress, and particularly for the brain, is not anymore only hemodynamic, but it could be the osmotic change. So there is a lot of study, there are some groups working on this topic, and we hope to find some solution to prevent or mitigate this risk, but I'm not so optimistic, except if we can move from, I would say, short 4 hours to longer or more frequent dialysis. That would be the only way to make sure at the end we can mitigate this type of risk.
Mm. And there's a question here about osmotic and electrolytic shifts, how they contribute to intradialytic morbidity and also maybe mortality. Is this something you can elaborate a little bit more on?
Sure. Yeah, 2 aspects, I would say. We can select almost all the electrolytes. So if we select, for example, the sodium, and I'm talking about the sodium concentration, I'm not talking about the sodium mass that we are removing, but acting on the tonicity of the patient. And this is why I mentioned this automated sodium control. If you just move from the regular negative or positive gradient to isotonic, so that means isonatremic dialysis, you reduce tremendously some effect of the osmotic shift. So it's shown on the clinical tolerance. You can see some beneficial effect on the cramps or some, I would say, patient reported abnormality during the dialysis sessions. This is one aspect on the sodium natremic tonicity. Now, if you move to another one, which is the potassium, as I've shown you, if you modulate the sodium fluxes, and particularly if you reduce the gradient, and the point is to make sure that flux of potassium are not so fast, you can reduce tremendously the arrhythmia. Now, if you combine potassium, calcium, and magnesium, then you can reduce, or you can almost suppress the arrhythmia. So the point is, of course, we have to consider all these elements. So potassium, which is associated with arrhythmic, I would say, condition, But if you combine potassium, calcium, magnesium, then you can be much more efficient. So just to give you, but now there are some centers or some researchers who are trying to make modeling of the potassium to prevent such elements. So maybe in the future we will have some, I would say, individualization of the potassium, but it is clear that if we reduce fluxes and the speed of fluxes, we can affect the cardiac arrhythmogenicity.
Then also there is a question about hemo or bioincompatibility reactions, how that can contribute to alter the outcomes. What are the main culprits here? Is the light complement activation that we see, could be a main trigger? This is a question.
Yeah, that's interesting question there. That's what I can report is the work from Poplar in Netherlands. He investigated a lot of patients focusing on the light complement activation, even if it's with a new membrane, with a new technology, with a new polymers and improve hydrophilicity of the polymer. There are still remaining, I would say, light complement activation. And it has been shown that the C3A, C5A, and C5B9, they are still activated within a dialysis. And interestingly, what Poplar shown and the group of Poplar show, it's some patients are activating much more this complement pathway, and then this is a predictive for the cardiovascular event. So maybe we have to consider, I don't know how, there are some personal specificity to identify so the phenotype of the patient who can be, I would say, at risk for the complement activation. So, of course, it's reduced. It's no more, I would say, comparable to what we observed in 40 years ago with the Prof membrane, but still, even at a 1 or 5% increase of this complement could affect the patient on the long term and could affect particularly on the cardiovascular system. Now, to be in line with the cardiologists, and I don't know if you follow the literature on this topic, but the cardiology field, aside from the nephrology, is really now excited by the complement activation. And particularly the patient affected by ischemic disease or cardiac ischemic disease, as soon as the complement is higher, the mortality risk is much higher. So there is some link with the outcome, poor outcome of the patient and the complement activation. So maybe we have to identify in dialysis patients some subgroup of patients a little bit more exposed to some, I would say, complement activation and cardiac risk.
Here's another question from Sula Stanfield. What is the burden of chronic anemia on the dialysis patient who is always in a state of tissue hypoxia?
That's a good question also. I don't know exactly. But of course, over the last 30 years, we corrected the anemia with the erythropoietin, the iron. So it's not anymore the same topic. But of course, reduce tremendously these hypoxemic consequences. But still, as I show you in the study by Kotanko groups, some 10% of the dialysis patients present some hypoxemic condition during the dialysis session. I don't know what is the reason. Well, even the group does not know. Is it some lung abnormality? Is it a fluid overload? Is it something wrong? But still, even with a normal hemoglobin, which is a 10 to 12, for example, they get hypoxemic. And this is hypoxemia. So we don't know what happened in the tissue. So the hypoxemic condition is a risk factor for the patient. So if you combine hypoxemia plus atherosclerotic plus hypoperfusion, of course, you get a tremendous risk for the patient and the organ who are suffering from the hypoxemic condition are always the same: heart, brain, and kidney. So that means there is a burden. So correcting the anemia, we know, but unfortunately we are stuck to 10 to 12 grams. Maybe we have to change a little bit this standard in some high-risk patient, but that's certainly something we can consider. And following the PO2 of the dialysis patient makes sense if we want to reduce this element. So maybe supplementing with oxygen such a patient would reduce the cardiac risk. I don't know. Maybe we have to develop some some study on this topic.
So I think with this, we should end this webinar. I'd like to thank you again, Bernard, for an excellent talk and answering all those questions very wisely. And I just, before we end, like to be sure that you register for our upcoming webinars. And we have one on Tuesday, November 15. There will be discussion about the clinical relevance of abstruse transport phenomena in hemodialysis. And on December 6, we have Christian Appel discussing informed decision-making in delivery of dialysis, combining clinical outcomes with sustainability. So please don't miss these exciting lectures, and I hope to see you soon. Bye-bye.